Hello everyone. In today's session, we're going to learn about one of the most common air pollutants, which is known to be potentially lethal when inhaled in high concentrations, which is carbon monoxide. I am Dr. Vidusha Vijay, and this beautiful presentation you're about to view was prepared by Dr. Himanshi Narang. Carbon monoxide is a stable oxide of carbon that is produced when there is partial oxidation of carbon-containing compounds. It is the most abundant atmospheric pollutant and is progressively increasing in concentration. The atmospheric concentration is generally below 0.001%, but it may be higher in urban areas owing to increased vehicular traffic and use of appliances, or in enclosed environments where there is lack of ventilation. It is one of the many ubiquitous contaminants of our environment, which is responsible for a large percentage of accidental poisonings and deaths reported throughout the world each year. Hence, it has also been given the name the silent killer. To understand the epidemiology, fire-related smoke inhalation is responsible for most cases of carbon monoxide poisoning. According to the data compiled by the National Crime Records Bureau of India in 2018, carbon monoxide poisoning is apparently responsible for up to 10 deaths per year. This appears to be a grossly underreported and misrepresented figure. Whereas in the United States, it accounts for up to 50,000 emergency department visits in cases of non-fire-related carbon monoxide poisoning and up to 1,200 deaths per year, which makes it one of the leading causes of poisoning death. Inadvertent non-fire-related carbon monoxide poisoning causes about 400 deaths annually in the United States, while the number of intentional carbon monoxide poisonings resulting in deaths is twice as high. Unlike intentional poisoning, unintentional poisoning demonstrates both seasonal as well as regional variation, and it tends to be more common in the winter months in the cold climates. This is because people tend to use heaters, gas geysers, fireplaces, and keeping the heater in the car running much more in the colder months. Morbidity, which is primarily related to the late neurocognitive impairment, persists beyond the initial stabilization in up to 40% of victims. To understand the prevalence of carbon monoxide poisoning, let's look at a few newspaper articles. The Mirror and the Daily Mail Online from the UK have reports of deaths occurring due to carbon monoxide poisoning. The CDC from the USA issues health advisory over carbon monoxide poisoning risks in the aftermath of Hurricane Laura. In Morena, Madhya Pradesh, 3 boys die of suspected carbon monoxide poisoning. In Delhi, 2 were found dead at home and the police suspect carbon monoxide poisoning. In Nepal, 8 tourists from Kerala were found dead, apparently a malfunctioning gas heater. In Mohali, 4 waiters die after New Year's party, carbon monoxide poisoning suspect. In Delhi again, 3 men found dead in a car in South Delhi in a case of gas poisoning. 2 maids in Dubai die of carbon monoxide poisoning. Mumbai girl dies after bathroom geyser emits carbon monoxide. Carbon monoxide poisoning risk rises during winter and during travel. And in France, Christmas Mass ends in carbon monoxide poisoning. So this helps us to understand that carbon monoxide poisoning is prevalent in all the countries of the world, and hence understanding the systemic asphyxiant can help to prevent its devastating effects, at least to a certain degree. Carbon monoxide in its pure form is highly poisonous, odorless, colorless, non-irritating, and lighter than air, which makes it very difficult to detect. It burns in air with a bright blue flame, and it is formed by the combustion of hydrocarbons. There are numerous sources of carbon monoxide. Incomplete combustion of almost any form of fuel tends to produce carbon monoxide. It could be wood, charcoal, gas, or kerosene. The exhaust of an automobile, fires, paint remover, especially methylene chloride, and tobacco smoke are common sources. The potential danger zones in a domestic setting would be the chimney, could be the heaters, car exhaust, cooking appliances, fireplaces, generators, any heating equipment, or even a grill. In the 1960s, it was discovered that carbon monoxide can be endogenously produced in the human body by the metabolism of heme to produce carbon monoxide, iron, and biliverdin by the enzyme heme oxygenase. However, endogenous carbon monoxide can never reach toxic levels on its own. The normal carbon monoxide level in plasma is in the range of 1 to 5%, and it could rise up to 7 to 8% in smokers. The usual fatal dose is expressed in terms of plasma concentration of the gas carboxyhemoglobin. The fatal dose is over 50 to 60%. Carbon monoxide concentration of 5,000 parts per million in air is lethal to humans after 5 minutes of exposure. The inhaled carbon monoxide is avidly absorbed by the lungs, of which 85% combines with hemoglobin and 15% combines with myoglobin. The elimination is exclusively through the lungs. Let us now understand the mode of action. Carbon monoxide has an affinity for hemoglobin, which is 230 to 270 times greater than that of oxygen. This makes it very easy for carbon monoxide to displace oxygen from hemoglobin and result in the formation of carboxyhemoglobin. So this event causes a leftward shift of the oxygen-hemoglobin dissociation curve, which affects the offloading of oxygen from hemoglobin to the tissues. So the net result is that there is decreased ability of oxygen to be carried by the blood and released to the tissues, resulting in hypoxia. Moving on to the pathophysiology. Carbon monoxide inactivates the mitochondrial cytochrome oxidase, which in turn interferes with cellular respiration. There is formation of carboxyhemoglobin. This reduces the oxygen carrying capacity of the blood, which in the heart causes cardiac damage, leading to dysarrhythmia. In the cells, there is activation of guanyl cyclase, which causes relaxation of the smooth muscles, and there is displacement of nitric oxide from the platelets, which results in vasodilation. Both of these together result in profound hypertension. The groups that are highly susceptible to carbon monoxide poisoning are infants who have higher respiratory and metabolic rates, pregnant women, the elderly, individuals with anemia or hematological disorders, patients with a history of ischemic heart disease or chronic obstructive lung disease. In pregnancy, carbon monoxide exposure is known to be teratogenic. It can cause a number of effects in the fetus, such as mental retardation, limb malformations, hypotonia, areflexia, microcephalus, low birth weight, seizures, and stillbirths. Now that we have an understanding of the toxicokinetics and the mode of action, let's move on to the clinical features. Most people begin to feel the effects of carbon monoxide at 70 ppm. This is a wonderful illustration which demonstrates how carbon monoxide poisoning can mimic the signs of a night out. Symptoms such as headaches, nausea, breathlessness, collapse, dizziness, and loss of consciousness. As with most poisons, the exposure to carbon monoxide can be acute or chronic. Acute carbon monoxide poisoning can be classified into mild, moderate, and severe. It is said to be mild when the carboxyhemoglobin levels are less than 30%, moderate when the carboxyhemoglobin levels are between 30 to 40%, and severe when the carboxyhemoglobin levels are over 40%. The symptoms observed in mild poisoning are headaches, nausea, vomiting, dizziness, and exertional dyspnea. The symptoms in moderate exposure could range from chest pain, blurred vision, confusion, weakness, increasing dyspnea, tachycardia, tachypnea, to a whole range of neurological symptoms such as ataxia, syncope, diminished dexterity, impaired task performance, prolonged reaction time, loss of muscular control, drowsiness, hallucinations, and we may even see tinnitus and cardiovascular toxicity. Severe carbon monoxide poisoning can cause symptoms such as trismus, muscle spasms, convulsions, palpitations, ventricular dysrhythmias, hypotension, skin blisters, myocardial ischemia, edema of the lungs, that is pulmonary edema, respiratory failure, involuntary evacuations, coma, collapse, and death. The classical features of acute poisoning are cherry red color of the blood and tissues, including the skin, which is usually seen only in 2 to 3% of cases, and the development of cutaneous blisters. There is erythema, blistering, and necrotic skin lesions on the hands, the legs, back, and the ankles. This is usually misdiagnosed as burns from the source of gas, and it is caused by muscle necrosis, which results because of the hypoxia. Carbon monoxide, which is a systemic asphyxiant, exerts its effects on almost all the organ systems of the body. In the eye, the hypoxic injury to the retina, which is caused by carbon monoxide poisoning, can be detected by the examination of the eye via electrodiagnostic tests, which reveal the presence of retinal hemorrhages. They could be superficial hemorrhages or hemorrhages deeper into the nerve fiber layer, which are called flame hemorrhage. There can be edema of the optic disc. The sequelae of these effects are paracentral scotomata, homonymous hemianopia, tunnel vision, and blindness, which could be temporary or even permanent. In the ear, there is sensory neural hearing loss. In the heart, acute carbon monoxide poisoning precipitates myocardial ischemia. In patients with pre-existing coronary artery disease, even low levels of carbon monoxide can precipitate myocardial ischemia. There are some electrocardiographic changes such as ST segment depression or elevation, T wave abnormalities, atrial fibrillation, and intraventricular conduction block. In the muscle, elevated creatine phosphokinase level and myoglobinuria are characteristic of acute carbon monoxide poisoning. Muscle necrosis, rhabdomyolysis, compartment syndrome are all seen. Delayed movement disorders could be present with lactic acidosis. In the kidney, hematuria, albuminuria, myoglobinuria, acute tubular necrosis, and renal failure are expected. In the skin, as discussed earlier, bullous lesions develop within 24 hours of exposure to carbon monoxide. There is an entity called as the post-carbon monoxide syndrome, which persists for 2 to 3 weeks following initial exposure to carbon monoxide. It includes headache, nausea, and weakness. There may be severe residual or delayed neurological effects, which can also occur after the acute poisoning. This is termed as the interval form of carbon monoxide poisoning. Demyelination in the central nervous system and other effects occur 48 to 72 hours after exposure. So the patient must be observed carefully for central nervous system and other post-exposure hypoxic effects. In the brain, the most commonly involved regions include lobus pallidus and the deep white matter. The signs and symptoms of post-carbon monoxide syndrome include apathy, disorientation, hypokinesia, akinetic mutism, confusion, severe memory loss, delayed loss of consciousness, coma, gait disturbances, fecal and urinary incontinence, speech disturbances, tremors, bizarre behavior, visual loss, movement disorders, chorea, peripheral neuropathy, Tourette syndrome, and Parkinsonian syndrome. The physical findings that a clinician might note would be masked face, glabellar tap sign, increased muscle tone, short-stepped gait, retropulsion, intention tremor, hyperreflexia, clonus, flaccid paresis, the Babinski sign, ataxia, and chorioathetosis. Chronic exposure to carbon monoxide produces similar symptoms as acute exposure, except for a few added symptoms, such as elevated RBC and WBC count, and permanent neurological sequelae like amnesia, which is loss of memories, agnosia, which is inability to process sensory information, apraxia, which is inability to perform familiar movements on command, even though the patient understands and wants to perform these commands. There's rigidity, personality changes, psychosis, blindness, and hearing impairment. Additionally, there are other symptoms which are similar to acute exposure, such as headache, dizziness, confusion, nausea, vomiting, hypertension, cherry red skin, aggravation of angina, albuminuria, and glycosuria. Moving on to the diagnosis of carbon monoxide poisoning in a clinical setting. The first step in diagnosis is to take a clear and adequate history, which will help raise the clinician's index of suspicion towards carbon monoxide poisoning. The additional investigations that might be helpful are determination of carboxyhemoglobin level, the normal being 0 to 5%. The levels are first determined when the patient is seen and then repeated every 2 to 4 hours until the patient is asymptomatic or the level is within the normal range. Beware of the pulse oximetry gap, where there is a discrepancy between the oxygen saturation which is recorded on a pulse oximeter versus arterial blood gas estimation. There is increase in lactate levels, increased anion gap metabolic acidosis, increase in this creatine phosphokinase levels, which is much more in carbon monoxide poisoning because of rhabdomyolysis as compared to a cardiac source. There's increase in troponin, which is again higher in carbon monoxide poisoning due to diffuse cardiac myonecrosis as compared to focal coronary artery disease. ECG findings are variable. It may range from normal to ST segment depression or elevation, T wave flattening or inversion, and arrhythmias. And on MRI, there is bilateral globus pallidus lesions. As I said, it is recommended to not rely solely on pulse co-oximeters to detect carbon monoxide poisoning. There are simple bedside tests which can be employed to help in the diagnosis of carbon monoxide poisoning. These are screening tests, and they are of three types. The first would be to take a drop of blood, dilute it with 10 to 15 ml of water, compare with normal blood which is diluted in the same manner, and the blood that contains carbon monoxide would be pink. The second test that can be employed is to add 0.1 ml of blood to 2 ml of ammonium hydroxide solution and vortex mix it for 5 seconds. The blood that contains carbon monoxide would be pink. The third test is to dilute 1 ml of the patient's blood with 10 ml of water in a test tube and add to it 1 ml of a 5% solution of sodium hydroxide. If carboxyhemoglobin is present, the solution will turn straw yellow if it's less than 20% of carboxyhemoglobin or pink if it's more than 20%. But in case of normal blood, the solution will turn brown in color. These are screening tests. A confirmatory test that can be used is the spectrophotometric estimation of carboxyhemoglobin levels. An X-ray of the chest can be taken, which would show ground glass appearance, perihilar haze, peribronchial cuffing, and intraalveolar edema. Most cases of carbon monoxide poisoning can be diagnosed with the bedside tests, X-ray, ECG, and ABG. However, for the sake of completion, let's discuss the changes that we would expect in a CT scan, an MRI scan, and a PET scan. The lucencies of the basal ganglia, particularly the globus pallidus, is characteristic of severe carbon monoxide poisoning on CT. Low-density globus pallidus lesions are predictive of neurological sequelae, and low-density lesions of the subcortical white matter representing demyelination or necrosis may also be seen. So the areas of globus pallidus as well as the subcortical white matter are indicated by arrows in the pictures. Whereas on MRI, there is cytotoxic edema and demyelination, as well as damage to the white matter and the basal ganglia. And on a PET scan, there is significant metabolic decreases in the orbitofrontal and dorsolateral prefrontal cortex, as well as the areas of temporal lobe with residual neurological deficits. Let's move on to the management of a patient with carbon monoxide poisoning. The first and the most important step is the immediate removal from the contaminated environment. 100% oxygen is given through a tight-fitting mask or an endotracheal tube. Monitoring of arterial blood gases with pulse oximetry, cardiac and respiratory status is necessary. Minor symptoms such as headache, nausea, and transient vomiting, and patients with normal mental status examinations and neuropsychometric tests are given 100% oxygen with non-rebreather masks, and they can be discharged once they are asymptomatic. Development of cerebral edema is assessed with serial neurological examinations, CAT scans, and fundoscopic examination. Cerebral edema is managed with hyperventilation by maintaining the PCO2 levels between 25 to 30 millimeters of mercury, head elevation of 35 degrees, and mannitol 0.25 to 1 gram per kg body weight of 20% solution is given intravenously over 30 minutes. It is important for the patient to understand that they must not return to such a contaminated environment. A few other pointers for treatment are Metabolic acidosis must not be treated aggressively. Severe acidosis, however, must be treated. However, a slight acidosis is actually beneficial. It shifts the oxygen dissociation curve to the right, thereby allowing more oxygen to be released to the tissues. So, it is important to avoid alkalemia. Sodium bicarbonate is not recommended. To prevent hypoglycemia, supplemental glucose is administered. Convulsions can be controlled with IV diazepam or phenytoin in the usual manner. And the patient must be instructed to avoid or at least restrict physical activity for a month after the exposure to minimize the incidence of cerebral demyelination. The antidote to carbon monoxide poisoning is considered to be hyperbaric oxygen. It involves the inhalation of oxygen at a pressure greater than 1 atmospheric absolute. 100% oxygen at ambient pressure reduces the half-life to just 40 minutes, whereas at 2.5 atmospheres, it is reduced to just 20 minutes. It increases the amount of dissolved oxygen by 10 times. Normally, a dramatic recovery of consciousness is seen. 30 minutes of 100% oxygen at 3 ATA is administered, followed by 2 ATA for 60 minutes, or until a carboxyhemoglobin level of less than 10% is achieved. However, there are some serious risks associated with the administration of hyperbaric oxygen, such as cerebral gas embolism, rupture of tympanic membranes, visual deficits, reversible myopia, sweating, palpitations, syncope, claustrophobia, and oxygen toxicity, which is evidenced by convulsions and pulmonary edema. Studies amongst victims of carbon monoxide poisoning indicates reduced incidence of neuropsychiatric symptoms in those who are treated with hyperbaric oxygen as compared to those who receive normobaric oxygen. However, keeping the risks in mind, routine administration of hyperbaric oxygen is not recommended in every case of carbon monoxide poisoning. So, hyperbaric oxygen is contraindicated in severely ill patients until they are stabilized. The indications are coma, seizures, focal neurological deficits, carboxyhemoglobin levels greater than 25, more than 15% in children and pregnant women, ischemic chest pain or ECG abnormalities, persistent neurological symptoms, presence of hypoxia, myoglobinuria or abnormal renal function, abnormal neuropsychiatric examination, and an abnormal chest X-ray. So to recap, in a potential carbon monoxide exposure victim, carboxyhemoglobin levels are obtained, ECG, ABG, CBC, and blood chemistries, and toxicology screen is performed. If the patient is unconscious at scene or in the hospital, new neurological deficit or mental status change is seen, end organ ischemia, pregnant women with levels over 20, and individuals with level over 25, hyperbaric oxygen therapy is suggested. In case none of these are seen, if the patient has headache, nausea, vomiting, blurred vision, or levels over 10%, you can perform 100% hyperbaric oxygen therapy until the levels are less than 10% and the individual is asymptomatic, but on an individual need basis. If not, you can discharge. The findings expected at autopsy are cherry red color of the skin, cutaneous blisters, cherry pink color of blood and tissues, pulmonary edema. The white matter of the brain is firmer, which helps the brain retain its shape much better after removal from the skull cavity. And in delayed deaths, there is necrosis and cavitation of basal ganglia, especially the globus pallidus and the putamen. Petechiae and ring-shaped hemorrhages may be seen in the white matter, and the heart may show focal areas of necrosis. Accidental carbon monoxide poisoning can be easily prevented. So, prevention entails the use of carbon monoxide detectors. These are the fastest way to detect and prevent carbon monoxide poisoning. They work just like a fire or a smoke alarm by sounding a siren when they detect carbon monoxide. They have a lifespan of about 5 years. It is recommended to place such detectors in every area where carbon monoxide sources are present, in the home, in the kitchen, basement, garage. The area should be far enough from the carbon monoxide source, but close enough to the areas that are usually occupied by the families. These detectors work by sensors that operate in 3 different ways. There is a biomimetic sensor. This has a gel which changes color when it absorbs carbon monoxide, and this color change triggers an alarm. There is a metal oxide semiconductor. When the silica chip circuitry detects carbon monoxide, it lowers the electrical resistance, resulting in an alarm. And there's an electrochemical sensor, where there are electrodes in a chemical solution which sense changes in electrical current when they come into contact with carbon monoxide, and this change triggers an alarm. These carbon monoxide detectors usually sound the alarm before a person may start sensing symptoms. At lower concentrations of 50 ppm, it may take up to 8 hours for the alarm to go off, and higher levels of over 150 ppm can trigger an alarm within minutes. When the alarm sounds, it is important for the person to act quickly because exposure to low doses over long periods can be just as dangerous as exposure to carbon monoxide in ultra high doses. These are some do's and don'ts to prevent accidental carbon monoxide poisoning. The do's would be to install a carbon monoxide detector in all high-risk areas and to change the batteries every 6 months, to vent all the gas appliances properly, to have any source of carbon monoxide poisoning serviced by a qualified technician every year, to keep vents free from debris which can block the ventilation lines. And don'ts would be to never use a charcoal grill, a lantern, or a camping stove inside an enclosed space, never leave a car running with the garage door closed, to not patch or seal vent pipes with unauthorized items which could leak carbon monoxide into your homes, never turn on your car if the tailpipe is blocked, never run a motor vehicle, a generator, or any other source of carbon monoxide less than 20 feet from an open window or a place where a vent can open up into an enclosed area, and to never leave a motor vehicle running in an enclosed or a partially enclosed space like a garage. These are some of the references that we used for this presentation. And on behalf of Dr. Himanshi, I would like to thank the Indian Society of Toxicology for giving us this wonderful opportunity. Thank you.